Welcome, everyone. And we are excited to have this first presentation in a series of programs that the League of Women Voters of the Bay Area is presenting to the community. This is a series of programs to raise awareness on the importance and value of the public health system in our communities as a vital part of the civic health continuum of the League in empowering voters and defending democracy, and to highlight the social determinants of health. Also, to raise awareness and potentially answer the question, is health a matter of personal responsibility or a public collective good? My co-moderator, Raina Larry, and I, Marie Ann Shovlin, are both board members of the League of Women Voters of the Bay Area. And we welcome all of you to this important presentation.
Thank you, Mary Ann, for the introduction. Welcome, everybody. Special thanks to our panelists for being here today. Back to you, Mary Ann.
Our two presenters are Dr. Clara Rudman, the Deputy Public Health Officer and Infectious Disease and Response Branch Director of the County of Santa Clara Public Health Department, and Kimmy Watkins-Tart, the Public Health Director of Alameda County and co-chair of the Area Regional Health Inequities Initiative. And I'm going to please, as they do their presentation, which they will do it in just a few seconds, please record any questions that you have in the chat area, and we will address your questions after their presentation. And now I'm going to turn it over to our excellent presenters.
Well, thank you so much. I'm just pulling up our slides here, and can I get a thumbs up from anyone to confirm that you can see them? Excellent. I see Raina nodding. Well, I'll dive in and then Kimmy, hand off to you, if that's all right. I'm Dr. Clara Rudman. My normal role is as Deputy Health Officer and leading our Infectious Disease and Response Branch. So everything sort of communicable disease related, as well as things like our lab, our pharmacy, and our ability to respond to public health emergencies, like the recent ones you're very familiar with. But I'm also covering our health officer at the moment and serving as health officer and department director. As Kimmy and I were invited together to speak to you today, we realized we had so much overlap in what we wanted to share that instead of presenting separately, we've combined our slides and we'll bounce back and forth between us, and then leave plenty of time for your questions at the end. Kimmy?
Thank you. My name is Kimmy Watkins-Tart, and I'm the Public Health Director for Alameda County. And so in our county, our structure is slightly different in that the role of the county health officer and the public health director are split. And so our county health officer is Dr. Nicholas Moss. And so the public health director role is the administrator. And so I oversee the public health department and all of its operations, its budget, and that sort of thing. And our county health officer, Dr. Nicholas Moss, is our health officer and advisor, and sets the content direction and helps with the monitoring and leads that effort, and is always, of course, our lead around any kind of infectious disease incidents and events, as you all saw in our pandemic response with COVID. So Sarah and I we think that we have put together slides that answer several of the questions that you all have raised for us. And so we are going to talk about briefly an overview of the role of public health and what role it plays in all of our lives. Very brief high-level history of public health and the accomplishments over the years, some of which you may be aware of and some you may not be aware of, as well as how the work looks and our approach locally within Santa Clara County and Alameda County. Throughout the presentation, we will have an opportunity to kind of go back and forth between this whole notion of, is it public or private and personal responsibility? And what you will notice in our presentation is that there is definitely interplay between those two perspectives and attention at times as well. And so we're hoping to have really engaging conversation and dialogue with you all around just that notion of, is it personal responsibility? Is it public? Is it both? So with that, I'll turn it over to Sarah to kick us off.
Thank you. So again, to start us off with, what is public health? When folks like Kimmy and myself talk about it, we often look to one of the folks who's really considered the founder of American public health practice, CEA Winslow, who was based at Yale about 100 years ago, who said public health is the science and art of preventing disease, prolonging life, and promoting health through the organized efforts and informed choices of society and organizations, public and private communities, and individuals. So just to kick us off, one of the fathers of everything that Kimmy and I do believed the answer is yes and both, that this is both an individual and public responsibility, that this is both an individual choice and an opportunity for us to think about everyone as a community and individual communities who are impacted differently as we think about health and what we're going to do as a society to improve it. So thinking about how we ended up with folks believing that, starting about 100 years ago. Before the 18th century, there were some sporadic public efforts, like a famous incident in London where someone named John Snow figured out that a cholera outbreak was related to a particular water pump in one area by doing some of what we still do today, mapping out where people are getting sick, trying to understand why, and using that and sort of our disease detective skills to understand what we might do to solve the problem. We also have used for really centuries the concepts of isolation and quarantine. When we don't have better tools to keep diseases from spreading from person to person, we separate people. And one of the things that's been so interesting about the last 4 years is you all saw this history speed up, where we went from, we have no tools except the things we used hundreds of years ago to keep people from getting sick, to where we are today, where we have very many modern complex tools and layers of tools that we can use to protect ourselves from a disease like COVID. But in the 19th century, you saw the sanitary awakening and many other tools other than just keeping people separated when they may be at risk of or have a communicable disease really came to the fore. And apologies to John Snow, that occurred in the 1800s. And then the New York City Health Department was the first public agency for health. And then the CDC wasn't formed until 1946, although there were remnants of other portions of similar United States task force that were especially focused on things like malaria prevention in especially war-affected areas. And part of the reason the CDC continues to be based in Atlanta is that early on in the 20th century, there was a fair amount of malaria spread in the southeastern United States, something we see so infrequently now that it makes headlines when we do see it, although this year we are seeing bits of sporadic United States malaria transmission. But for a very long time, it has been incredibly unusual. And then now, over the last 50, 70 years or so, we've really seen an evolution of public health and public entities that think about public health focusing purely on communicable diseases, to then thinking about chronic diseases, injury prevention, and what role we look to as a society to prevent everyone from developing these other diseases, not just that are based on communicable transmission from person to person. So with that, I'll just frame some of what we have seen in the last century as some of the most powerful public health achievements, are places where, instead of looking to individual action to make a change in the health of each individual, therefore adding up to a community, we've leveraged new tools, policies, and structural changes, environmental changes, to change entire swaths of a community's health. So examples, and one that I think we talk about frequently, are seatbelts, where just 50 years ago, they were almost unutilized. And through a combination of research, public education, policy changes and structural changes like not only requiring individuals to wear them, but requiring car companies to build them and make them comfortable and continually safer and part of an expectation that's required of everyone, it has become very surprising to see someone driving without a seatbelt now. And as a result, car crash fatalities are significantly lower than they used to be, although still a topic of public health attention. Similarly, we've seen considerable changes around tobacco utilization and the harms that that causes, again, from a combination of research, community engagement, individual education, but also policy changes. Another major one I'll touch back on at the end of the talk today, fluoridation. We know that cavities and dental health has actually a really considerable effect on people's lifetime ability to have other positive health outcomes and other economic and other social benefits. And requiring fluoridated drinking water has actually been a massive public health benefit. And then two others I think we'll talk much more about today. One is vaccinations, and especially right now as we're headed into the winter virus season, this one's top of my mind. The other is understanding the connection between structural racism and all of the major health disparities that we see really across the United States, which I find to be both incredibly heavy, thinking deeply about how centuries of oppression have led to what we see in people's health outcomes today, but also how having that understanding and drawing those lines is giving us new tools to understand how to lift entire populations to better health, including focused activities that do things like support Black women through their pregnancies, understanding, actually, as I talked about with this group the last time I had the opportunity to present with all of you, about the really dramatic and upsetting disparities in neonatal and pregnancy outcomes for Black women compared to other birthing parents in the United States. So I believe with that, I'll pass back to Kimmy.
All right. So this next segment is really just providing an overview of governmental public health and what our systems and structures are. Next slide, please. So what we have here are the public health foundational areas and mandated services. And all public health departments across the country are expected to have competency in several areas, such as emergency preparedness, which you saw with our pandemic response, policy development and support. So that's a requirement of all public health departments. Developing and implementing programs and services and policies that aim to achieve equitable health outcomes, such as birth outcomes. The departments are also charged with having programs and services in these areas. And so what you have communicable disease control, chronic disease and injury prevention, maternal, child, and family health, environmental public health, and access to and linkages to clinical care. We say in public health that, I'm not ready yet, sorry, that when you've seen one public health department, you've seen one public health department. All of our departments are structured very differently, but what you will see is you will see these 5 areas reflected in some fashion in all public health departments across the country, with the exception of, I would say, environmental health. Often environmental health is not part of the public health department. In our county, it is not a part of the public health department, though it is a part of our health agency. I believe it is now a part of a public health department in Santa Clara County. After having a stint outside of public health, it has returned back to public health. But we're always working close with environmental health, whether they're in the department or not. In addition, I have this one little piece here listed around mandated basic services so that you can go check this out if you like. Public health nursing is also codified in California, as well as in some other states, but not all states, where having public health nursing services is required in California. Next slide. This is our organizing frame, if you will, for public health nationally. And this is something that local public health departments, state public health departments, as well as other territories use to organize our work. And this is kind of like the framework that we're all operating with. The three core functions of public health are on the outside of that wheel: assurance, assessment, and policy development. And then you have inside 10 essential services listed, and they're listed around equity. And they're listed around equity because it is expected that equity will pervade all the areas of those 10 essential services. Everything hinges on our consistent ability to apply equity to every single thing that we do. And when I say equity, when we talk about equity, what we mean is that everyone in a geography has a fair and just opportunity to be as healthy as possible. This requires that we all be able to name, address, and remove obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness, lack of access to good jobs with fair pay, quality education, housing, safe environments, as well as healthcare. When you look at the first area, and that's assessment, there are two services embodied in that one function, and that's monitoring population health and investigating disease. Sarah talked a bit about the investigation of disease as well as monitoring health, and that has been a service of public health for decades, for hundreds of years. When you go to the second area, that's policy development, there are three areas under policy development. They include effective communication, partnerships with the community, planning and policy development, and enforcing public health laws. The last core function is assurance, and all the rest of the services are listed under assurance. And under assurance, you have equitable access, having a skilled workforce, which right now is very challenging for all of us. Finding and hiring skilled employees to be part of all of our public health departments is top of mind for everyone across the country. Evaluation and always improving the quality of the work that we do. And last, but certainly not least, having a very strong public health infrastructure. Next slide. This shows essentially our public health system in this country. And so when we say public health system, that's not the same as a public health department. In the yellow in the center, that's your public health agency. It could be your local public health department. If you're in a place like even Alameda County, we are very fortunate, and it's very unique that we have a city public health department and we have the county public health department. The city of Berkeley has its own public health department. Both Sarah and I were in other places around in Las Vegas, as well as in Long Beach with our associations. Long Beach is a city public health department. And so you will always have your public health agency, whether it's city, county, usually is county in California, at the center. And then you have all these different stakeholders that make up our public health system. You have community centers, you have hospitals and doctors and clinics, you have law enforcement, you have civic groups, you have elected officials, faith institutions, you have labs, you have schools, you have fire, you have transit. What's not here, I don't think, and critical, are residents, people. And so residents also, but they are embodied in neighborhood groups here in this, but wanted to really lift that up. But bringing the voices of residents to the forefront is really critical in making our work more effective. Next slide. This, and I'm sorry, you might not be able to see it very well, but this is a map that just shows how public health departments are structured in this country, and it's color coded to show that some public health departments are centralized, some are decentralized, and some have a hybrid. So in California, we have a decentralized structure, meaning that while we have a state public health department, which is the California Department of Public Health, most governmental public health operates at the county level, and it is run at the county level. Therefore, your public health department staff are going to be employees of county government. In places like Pasadena, Long Beach, and the city of Berkeley, those public health staff are the employees of the city. In a centralized state, everything emanates from the state public health department. And then all of the employees would be state health employees. And then they would have kind of field offices throughout their state. And then there are states that have some mix of centralized and decentralized. And so what's important is wherever you're living, to know how your public health departments are structured so that you can know how to get involved. What I like, and of course, because I grew up here and I work here in California, I like our structure in California, being decentralized. But what I like about it is that having governmental public health operating at the local level means more opportunity for resident voice. With everything happening at the state in a place as large and diverse as California, we could, if we had centralization, have a situation where decisions are made at the state that may not make sense in our local context at a city level, at a neighborhood level. And so when we're operating at a county level, though, we are able to get to know people very intimately and build our public health system and our responses to meet their needs. Next slide. This is essentially more about our structure at the national level. We have the Department of Health and Human Services at the federal level, and then we have both the Centers for Disease Control and Prevention and Indian Health Services. Next slide. This is the structure at the state and within California, California Health and Human Services Agency, and then two branches are California Department of Public Health and the Department of Healthcare Services. Most local public health departments take all of their instruction and governance from the California Department of Public Health. However, because we provide a lot of direct services, we also work a lot with programs on the side of the Department of Healthcare Services. And in California, DHCS runs our Medicaid program. So any services that we provide in public health that are going to be billed to Medicaid requires that we also participate in what's happening with DHCS. And so we're walking in both worlds. Next slide. Many of you have seen this picture or some iteration of this picture, but this is really a way to remind ourselves that equity really is something that we are envisioning happening in the future. And we don't have it now, but we are looking towards that. And I like this particular version because this shows really what things are like on the left, the reality, that things, the playing field isn't really level. It never has been, and it's not now. And this is kind of what it looks like. And so if you provide in the next picture, everybody with the same thing, and this is a really hard thing for us, particularly in this country, that we are very rooted in this notion of equality. You get a nickel, I get a nickel. But if you already are a billionaire, do you need a nickel? I may actually need 3 nickels. And shouldn't I get them so that I can have the same opportunity that you have to be able to see the ball game? Equity means giving what is needed. And for a lot of people, this is a hard concept because it does sometimes mean that you will give more to some and less to others in order for everyone to reach the same outcome, because that's the goal. It's not about how much you get, it's about what you're able to do and the outcome you're able to get to. And so in the end, of course, we would like there to not be any barriers for anyone. And that would be true liberation, where we can all see the ball game. There isn't a fence in front of anyone. And it doesn't really matter then how tall you are or whatever. We can all see. Next slide. I'm going to turn it back over to Sarah.
Thank you. So in terms of what we do as public health, often we actually find ourselves talking about how we do it more than what the content areas that we're working in. And I think one of the background pieces that helps explain why this is the case is that network Kimmy showed you, where the public health agency or your public health department may be in the middle of a network where in order to achieve public health, we need community groups, we need individual voters, we need individual community members and community leaders, we need healthcare delivery, we need law agencies and fire. So it is an entire team effort across many types of organizations that are going to have different skill sets, different expertise, and different resources. So often you'll hear us talk about taking a public health approach to a problem that is resulting in poor or inequitable health outcomes, even if we're asking agencies other than just the public health agency to take this public health approach. And so some of how we describe that public health approach is listed out here for you. I think some of the most important principles are that it's based on data and scientific evidence, that we frame the issues based on what are the impacts to health and the impacts to equity, that we listen to the voices of the people who are actually most impacted by the problem we're trying to solve, and ensure that they not only are given an opportunity to explain what the problem is and what they're experiencing and validate the evidence and data we think we've got, but then are both the recommenders and decision makers in what solutions are actually going to work. Then we also approach those solutions through partnerships where it may not be the public health department actually delivering the service that is needed to enhance health. It may be public health providing assistance to a faith-based organization or a community organization or an educational organization. And then it may be that we are advocating for those agencies to take the lead, or we may be a partner in providing the services directly. And that's especially where we find ourselves in those required service delivery areas Kimmy highlighted. In addition, we are constantly looking for what I think of as the upstream solutions, as opposed to waiting till somebody floats all the way downstream in a problem and, for example, needs a treatment for a disease. I'm looking, can I stop them from ever getting that disease? Can I stop them from ever being at risk for that disease? What is the most upstream way that I can help make sure I keep somebody healthy for their entire life course and in a way that is equitable so that I'm providing that service, that change, that environmental shift for the people who need it most? And often that requires identifying the policy solutions that are going to make changes. So back to our seatbelt example, if we had only ever said, we're just going to put information out there about how dangerous car crashes are, a lot of people would have said, this is really terrifying and upsetting, but what am I supposed to do about it? And then if we said, okay, well, we're going to tell you you should wear a seatbelt. And then they're going to say, well, but my car doesn't have one. Then we're going to say, well, you should pay more for a car that does have one. Folks might say, well, I don't have the money to pay more for a car that has one. I need that to pay rent. I need that to buy food. So using a policy solution to say, actually, car manufacturers, you're required to put seatbelts in every single one of your cars and make sure they work and keep improving them and make sure that you're not penalizing the purchaser of the car for that added safety activity. That is the policy level solution that's actually going to enable people to take advantage of what we know will keep them healthy and safe. And then finally, connecting people to these services. If we had only made cars that had seatbelts but didn't tell anyone why, or help reward them for using it and help them understand that it made them safe, take feedback about when they were uncomfortable and how to make them safer and more comfortable, then we would have failed just as well. So connecting people to the resources once we've enabled them to be created is a big piece of this public health model. So the question of how we do that involves communications and educational campaigns, programs that are really co-designed with community groups that are going to enact them, often public-private partnerships, making sure that we have advisory boards and commissioners who can tell us how we're doing and how we need to change what we're doing, have robust outreach efforts so that folks know about the changes that we're making available to them and take advantage of them. And then often this requires direct support to community-based organizations where folks on the ground who are the folks most impacted by a health problem are actually the ones creating the solution. Often that is the best way to achieve it, and public health actually therefore has a big amount of infrastructure devoted to getting those resources out to the community to make sure they can do that work for themselves and have the resources to do so. So just some examples about how we do this. This means that we have to partner formally as well as informally at the national level across health departments so that folks like Kimmy and I can put our heads together and say, well, what's working for Alameda? Maybe that could work for Santa Clara and vice versa. And then to advocate on the state level and federal level for those policy changes, like make seatbelts required in every car and make it illegal to ride without them. And so it's through these collaborations and making sure that they're resourced to support us and vice versa that we can actually make these policy level changes. But we are doing this work in the face of some pretty extreme and long-standing barriers and challenges. One, as I mentioned, we are all very aware of the way communicable diseases can humble us. And I'll talk in a moment about how these issues are interrelated and how, while even though the history of public health shows that we've made steady forward progress in making sure fewer and fewer people die of communicable diseases, it continues to be a major threat and therefore a major work of the public health department to continue to protect people from those threats. But at the same time, most Americans are not dying of communicable diseases. They're dying of chronic diseases like heart disease and diabetes and cancer. And so that then has to become a huge focus of what we do in our work. And making sure that people have access to the types of environments and resources they need to avoid chronic disease or to live long, healthy lives with them if they've already got them. That's another big lift for the public health department that takes this same level of complex collaboration. And then we're doing this in the context of climate change, both human created and other related elements of it that impact us, that are doing things like moving which mosquitoes live where. For example, for many years, we had really no malaria spreading in the United States, but the hotter it gets here, the more likely we're going to see the mosquitoes that spread malaria or different mosquitoes that spread other diseases like yellow fever make their way farther and farther north in the United States, creating new challenges for communicable disease control. Likewise, the more heat-related emergencies we have, the less likely people are to be able to get outside and exercise in a way that can help them prevent the negative outcomes of chronic diseases. So those are just some of the ways that these problems are interrelated. Another layer that adds complexity to this is increase in homelessness. And at the base of that, some of what we'll talk about in a moment with systemic racism, income inequality, and lack of access to housing and housing justice. That the increase in homelessness across especially the Bay Area is a major barrier to achieving what we know we otherwise could with respect to prevention of communicable diseases and harms from chronic diseases. Because you can imagine, as hard as it is to check your blood sugar 4 times a day and take your insulin on time, it is impossible to do it if you are living in a car or on the street, have nowhere to store your insulin, have nowhere to store your finger stick supplies. And then on top of that, all of these problems exist in a country with centuries of systemic racism. And that infrastructure or that background means that we are seeing the inequities across outcomes in every one of these categories. It's those systems of both state sanctioned and promoted government sanctioned and promoted racism, as well as interpersonal, over centuries, over generations, that have led to the very different outcomes we see in who gets what chronic disease, who gets what communicable disease, and how well they can survive once they do have it. And I'll say, and I think this is probably apparent to a group like you all, massively overlapping with homelessness as well. When we look at who is unhoused in our communities, it is much more likely to be people of color. And it's also significantly overlapping when we talk about climate change, because in addition to thinking about what can we do as a human race to stop the trends with climate change and say, I'm going to choose to use a different kind of heating, a different kind of car, a different kind of stove, the people who have the money to make that choice are much more likely to be white people. The people who don't have the opportunities to make those choices are much likely to be people of color. And then when we have climate-related disasters, whether that is fires or heat-related emergencies or air quality emergencies, systemic racism also layers on and respective inability to be able to be resilient in the face of that. The folks who can work indoors for the day, the folks who can wear a mask for the day, the folks who can afford to air condition their house for the day are much more likely to be less impacted by these centuries of systemic racism. So with that, checking if I'm passing back to Kimmy yet. Oh, no, I'm going to tell you about Santa Clara County and then pass to Kimmy to tell you about Alameda. So how do? We just told you for half an hour about how much work there is to do in a public health department and as a member of this wider public health infrastructure. And again, Alameda and Santa Clara County have structured the way we do this work a little bit differently, but you'll see a lot of similarities. So first, our vision and mission and core values are really tightly aligned with what I've already shared around creating an equitable world where all people thrive in healthy and safe communities, and doing the work to protect and improve the health and well-being of our community, and doing it in a way where our top values are equity, diversity and collaboration, accountability, integrity, and impact. So public health in Santa Clara County recently updated our strategic plan. And what we found as we looked through what are the top priorities for us as a department, it was much less about the content areas, although we all agree that climate change, housing, substance use, mental health, chronic disease, injury prevention, that's what we're doing. But what we wanted to make very clear was how we were doing it and why. And so our top priorities instead call out those elements that is always about racial and health equity, and that we are achieving it through policy change, partnerships with community, achieving technology and data that we wish we'd had before the pandemic hit us and making sure that we are never that far behind again, and building and sustaining the workforce that we need in order to do what I've described. And so in Santa Clara County, we often picture ourselves, as opposed to a sort of traditional org chart, as a tree, where there's an office of the director at the root sustaining everyone. I know, how public health is that we like a green tree growing outside with sunshine and water. So if you wondered how I could do Kimmy's job and Dr. Moss's, the answer is I don't. I have an entire team that helps me do it, including deputy directors as well. And then our branches of the tree focus on some of these content areas: infectious diseases, environmental health, healthy communities, where we focus on injury prevention and access to safe, healthier foods and safe places to exercise, a maternal, child, and family health branch focusing on some of the nursing and birth outcomes that Kimmy spoke about earlier. But the trunk of our tree is something we only built during the pandemic, what we're calling the science branch for short, or science, epidemiology, informatics, and improvement. And this is everything we should have had 10 years ago to put us where we needed to be at the beginning of the pandemic. This is informaticists to make sure we have 21st century data systems and we're not waiting for faxes to come in to find out who has COVID. This is health economists to help us understand what are the real impacts to people as we make proposed changes and try to help people have opportunities to be healthier. This is folks who will help us collaborate with academics and evaluate our work to know, is it really working, and help community groups do the same thing. But again, we didn't have this just 3 years ago, 2 years ago. And so because of that, it's sort of one of our most jeopardized components of our infrastructure. It's relatively new. The funding that built it came up during COVID and is sunsetting in the next year or two. And it doesn't have the political appeal of work where I can show a picture of a human being helped by a public health department staff member. It's somebody in a back room in front of a computer telling us this is the right thing that's actually going to make your world a healthier one, which makes it hard to lobby for, or educate folks about the power of it. So something I'll point out to you that I think this is the kind of infrastructure that a 21st century health department will have, but certainly not everyone has been able to build. And now I will share over with, pass it back over to Kimmy.
So I'm going to flip mine and I'll talk about our content areas. We recently first and along the way a little bit about the how we're going to do these things. And so recently we conducted our community health needs assessment along with health system partners in Alameda County. So that included Sutter, Kaiser, Stanford Valley Care, and UCSF, Children's Hospital. And we collectively looked at all of our data as well as talked with community stakeholders throughout Alameda County and identified 3 content areas for focus for us for the next 3 to 5 years. And they are access to care, which is very, there's a lot in there, but what we heard people say over and over and over again, that despite the efforts that California has made to make sure that everyone has coverage or get as close to universal health coverage in our state, we still have a lot of access gaps in terms of services. Physical health services, oral health services, and behavioral health services. The residents of Alameda County, literally all the focus groups, all the ages, all the racial and ethnic groups, they all said, we still have a hard time getting the health services that we need. And so access was huge. We also heard people say that promoting economic security and economic opportunity was a big deal. And this is going to be the hardest one probably for us to tackle as a health department, because this is definitely not an area of expertise that we have necessarily. But if we weren't working in a public health system, like Sarah and I both talked a lot about, we would not be able to even approach this in any way, shape, or form. But we have confidence that through the partnerships with folks in Alameda County, we will be able to come up with some goals and objectives and some projects under economic security and opportunity that will meet the community's needs. Last but not least, communities and individuals are free from violence. And so recently our public health department stood up a new Office of Violence Prevention. We've always implemented strategies to prevent violence from occurring, but we never actually had a Office of Violence Prevention or a violence prevention program in our public health department in Alameda County. So those are the 3 content areas we're going to be focusing on. And the strategic priorities, which for us are the inwardly facing activities that are really supporting those 3 content areas, include our public health infrastructure, so our basic infrastructure. So we asked ourselves very similar question as Santa Clara County did in terms of what do we wish we had had at the beginning of the pandemic, before the pandemic. And so equitable practices codified and institutionalized in our department was a big deal, because if we had had those practices fully embedded in our department, it would not have been as much of a struggle when it came time to roll out the vaccine. The prioritization that the, oh, cute, a little kitty, not so little. But if we had not this, we had the prioritization that was given to us by the feds and the state, but then there came a time when it was like, okay, well, anybody can be vaccinated, but we still had deep disparities. And so we had to really strengthen our equitable practices in the middle of rolling out the vaccine. And that was really tough. Technology and health informatics, Sarah already mentioned that. Cross-departmental partnerships. Our public health department is relatively large, and so we still need to do a better job of working with each other to coordinate inside of our department. And last but not least, community partnerships. Next slide. Our county has been centering equity for a really long time, and so we still envision a time where everyone in Alameda County will be able to lead a healthy, fulfilling, and productive life. And our mission really kind of embodies a lot of what I've already talked about, what Sarah and I both have already talked about. partnerships, community, a responsive and dynamic process. And one of the things that is important for you all to know is that Sarah and I and all of our colleagues, we are stewards in this moment, but we're always looking at what's ahead and what do we need to do now to ensure optimal health and well-being for the generations ahead of us when we're no longer in the department, when we're no longer there. And so that's a very tall order, but it's also very invigorating for me to know that I'm not just working for the here and now, I'm working for what's here when I'm no longer here. Next slide. And this is a very traditional and not pretty at all org chart. Okay, Sarah, I need to come up with a
Just
nice
to draw you a
photo.
tree. We'll work on it.
Yes, a tree of our public health department, some of the same programs and services that you would have in Santa Clara County are part of our public health department. Our 4 operating divisions are nursing, communicable disease, family health services, and community health services. Next slide. So this next segment are just some highlights of some policy work. Sarah spoke a bit about the upstream work, and these are some things that we've involved ourselves in Alameda County, but they're similar to things that also go on in Santa Clara and other counties as well. This first is the implementation of AB 617. And so when that legislation was passed, that really required the state to partner with and work with local communities that met certain criteria to help with planning for emission reduction plans. And so we have 2 communities that were approved in Alameda County. It's West Oakland and East Oakland. And so we were asked to be part of the community steering committee for both of those processes. West Oakland, and this is a copy of their plan. Their process is over, and now they're in implementation. And these are some of the things that really were lifted up as recommendations that came out of that community process, that they wanted us to expand our asthma program. They also wanted to see the full implementation of healthy development guidelines. So in Alameda County, we partnered with community groups to develop what we call healthy development guidelines for the city of Oakland to use in their development projects. And last, the residents are really interested in us replicating a residential weatherization program that actually is being implemented in Contra Costa County as a way to mitigate against poor air quality. Next slide. And this work, AB 617, is happening throughout California. And so Alameda County is not the only county doing that work. We talked a lot about homelessness. We know that housing is a huge issue. So the conversation, of course, around tenant protections should not be surprising. There are conversations happening everywhere around tenant protections. And we are knee deep in those conversations here in Alameda County to work with residents, work with community groups to push for the strongest tenant protections possible. What we saw with our moratoriums, eviction moratoriums, is that we saw the number of people becoming homeless every day going down. But of course, now it threatens to go right back up because all the moratoriums have been lifted. And without having something more permanent in its place, we're going to possibly get back to that data point of, in our county, for every person that we got into permanent housing, 3 more people became homeless. And so it's like, we got to stop that spigot. We got to turn the spigot off. And it's not going to be educating people around where the next shelter is. This is some deep policy work that has to happen, local, state, federal level, to protect tenants, build more housing, more affordable housing for everyone. We have a ton of work collectively we need to do to house Americans. It is unconscionable that in our country we would have anybody living outside. It does not make any sense. Next slide. I'll climb off my soapbox now about that. And this is more around healthy development, what we see, and it's definitely pervasive in the Bay Area, displacement and gentrification. And it doesn't have to be this way. There's a way that we can have good development. We can revive and bring communities back to life without displacing the people that are already there. But it does require a collective action and collective awareness around the tools that are needed to develop without displacing people. But it actually can be done. I haven't seen it happen that much, but it is possible. I think that might be the last example.
I snuck one slide.
Great.
So,
Go for it, Sarah.
Yes, and yes, and yes to everything Kimmy just shared. And I want to flag, in addition to those, a few things we're thinking about in Santa Clara County. I think one is, so much of how that I think a group like this is very knowledgeable about is that, and I'm seeing based on the questions coming in the chat, that we need to make sure Americans have access to healthcare. There are major areas where, for example, Medi-Cal and Medicare do not pay for screening for diabetes. Once you have it, it will pay to treat you for it, but checking if you have it is not actually covered. So those kinds of gaps need to be closed. And we can certainly talk longer about bigger systems changes that would have even greater impact. In addition, policies like paid sick leave have a really important impact, and I think, again, became very highlighted during COVID in understanding whether people even have the opportunity to protect their health when they need to, or whether they have to bring a communicable disease with them to work because otherwise they can't survive, can't keep their housing, can't keep food on the table. In addition, we're paying attention to some of the loopholes in existing public health policies, like while flavored tobacco has been banned in California, which has had a major impact, we think, on youth starting to smoke and vape, there are loopholes for things like sensation flavors, where it's not mentholated, but it's cooling. In addition, while we're seeing improvements, although still room to go, in cannabis legislation to help make sure that anyone using cannabis is doing so safely, hemp products, which are designed to be non-intoxicating, have a loophole where they can then be concentrated in a way that makes them intoxicating, and they're regulated completely differently. So loopholes there. A final one, we talked at the very beginning about how important fluoridation has been to increase dental health across the United States. In California, the law says you've got to fluoridate your water unless you can't afford it. And then water company, you don't have to. And that's actually a major hit for us in Santa Clara County, where most of the water sources in San Jose are not actually fluoridated in 2023, which blows my mind. And finally, I think to do all of this work, we need the resources to do it in the public health department, or to help get the resources to the right entities, whether that is law enforcement, community groups, faith-based groups, et cetera. But we also need that funding to be sustainable and flexible. Often funding will come down from either the feds or the state in a, you may treat this disease in this population for 2 years. And when we get funding in that way, it's still much appreciated, but it doesn't actually help us build a system that's going to keep a population healthy. It often is just enough to help us buy Band-Aids and put them on if we're lucky. So thinking about how to help us do the work, often we'd rather have a little money for a long time than a lot of money one time. So with that, I think we just have a quick wrap up for you. Kimmy, I'll hand back to you.
Just wanted to underscore that we all have a role in keeping our communities healthy. It's a public health system. We may be the conveners of that system, but we don't do all the things. We can't do all the things. We need all of you to help make our communities healthy and safe. Thank you.
Thank you. So we had a lot to say. I've seen some fabulous questions come in the chat, but I'll look to you, Marianne and Reina, to help lead us through the questions.
Okay.
Well, thank you so much for a very enlightening and informative discussion today. We definitely need more than Band-Aids, and you're already talking about long-term solutions, so that's great. So we have a question from Marian Shostrom in the chat that I saw come in, but somehow, Marian, can you see that question? My chat seems to have disappeared.
Yes, what Miriam is asking is, how will Governor Newsom's veto of the bill limiting the cost of insulin affect the work that you are doing in your public health departments?
Yeah, look to you.
I mean, I can, I'll start by saying that, and I think Sarah alluded to this earlier, that when people can't afford to buy medicines that they need to treat a disease, then what we're talking about is we're increasing the likelihood of early death and disability. If that person, and most people are tied to family and community, it impacts the whole ecosystem that they're in. And so to not be able to afford the medication that you need, I mean, we can talk all day about healthy eating, active living, but once you have a disease and you need a medication, that's the other part of the package. You got to have it. And so that's what that means. That means that if people can't afford it, they won't get it. They won't have it, and they won't take the insulin, and they'll be in and out of the hospital, in and out of the emergency room, and progressing pretty rapidly to end stage diabetes. And the diabetes is one of those diseases that just kind of ravages your body over time without, proper care and treatment. And so
Okay, thank you. So Director Watkins, I had a question about Bar High from you and your work on health equity there. So how does that tie in with your work in public health?
So Bar High is a coalition that we created in the Bay Area. And it was convened and started and founded by public health directors and health officers in the Bay Area. And so we came together to address health disparities. We were noticing in all of our counties that there were these deep disparities and a lot of different health issues, and we were all trying to tackle them in our own way. And so we thought, well, maybe we should work together to address this. And so then we built this coalition ourselves and named it the Bay Area Regional Health and Equities Initiative. And so the way we generally operate in Bar High is that it's a membership-driven organization. So we pay dues and we work on things that are in addition to what we do in our individual counties. So we don't replicate anything that is already happening in counties, but we try to select strategies and activities that are additive. And a good example is we recently, there were a few counties in the Bay Area that got funded to do perinatal equity work, to work on those birth outcomes that Sarah mentioned earlier. And so those counties that were funded by the state of California to do that work decided that they wanted to do a communications campaign. Communications is one of the things that is done really well in a regional kind of way because we share a media market in the Bay Area. And so those counties got together and we pooled our money and we situated it with Bar High. And then they were able to help all of us coordinate a campaign around perinatal equity and birth justice. So that's an example of how we work also together as a region. Transportation policy and planning. Transportation is regional. And so Bar High plays a very significant role in helping us to advance equitable policy solutions when conversations are happening about regional transit for the Bay Area. And so those are some examples of how Bar High works side by side with our public health departments, but never duplicating anything.
And if I can add one piece to that as well, I think when it comes to taking that public health approach to say, how do we go all the way upstream to the root of a problem, in this case, inequitable health outcomes, and start there with what's going to be most powerful, Bar High's policy agenda really does that beautifully. So if you want to go take a look at that, I think it thinks, especially at the state level and the Bay Area level, what are these state policy changes that are really going to change the fact that skin color is a major predictor of how long you're likely to live.
This has been a wonderful presentation. The comments that I'm seeing in the chat are people really appreciate the work that you do and the programs that you're looking forward to. And I do have maybe what would be the last question, because we are at the top of the aisle. What do you see, both of you, what do you see as the role of public health in the future? Given that we've gone through COVID and the challenges we had there, and the challenges that we're looking at with climate change, what do you see as the role of public health in the future?
I can jump in to say, here's my dream for what the role of public health will be in the future. That we are resourced to play a role where we are able to lift up the voices of people who are most negatively impacted by poor health outcomes, listen to the solutions that those populations tell us will work and that they need, and then help get the resources and funds and evidence and data to help folks do that work. And we play the role of being the convener and the evidence gatherer, and help to recommend policies, help to highlight health impacts of various policies and systems, help to help community groups evaluate their own work so they know what's working and where to dive in and how to ask for more support for what's definitely working. And I think we are making really important steps in that direction, but I do think it's constantly jeopardized, because I think there's a sometimes this sort of false assumption or desire to take money away from healthcare delivery for public health, or take money away from public health for healthcare delivery. And we really, that really leaves us robbing Peter to pay Paul. And if there are other places where we can fund both, because we need to both help people who are sick right now and continue to invest in making sure nobody gets sick in the future.
Yeah. Thank you. And Kimmy, did you have any comments on that?
I would just like to add that I am hoping that public health is going to be able to continue to be a voice for health for all, because again, in this country, there's no excuse, absolutely no excuse that we don't have health for everyone and health care for everyone. And I'm hoping and dreaming that we are able to get back to our roots in public health, and that we're able to be funded for and supported in looking at population health, all those things that make populations healthy. As we look at our national infrastructure and we see the degrading of the infrastructure that was invested in so many years ago is starting to break down. The lack of infrastructure in urban areas and in suburban areas is what was those were major drivers of disease and early death many, many years ago. And so nothing has changed in terms of 1 + 1 is 2. So we still need to have all of those health protections. We still need to have good sanitation. We still need to have, good quality housing, all those things. And so I'm just hoping that public health can be a voice, and that we can actually put more public resources back towards those things that we know keep people healthy.
Thank you so much, both of you. This has been a tremendously revealing and educational hour. And we really appreciate both of your roles in our public health system in Alameda and Santa Clara County. And I can have nothing but kudos and lots of applause for what you are doing, and how we can work with you, the League of Women Voters, and our programs and our policies to support the work that you're doing. Thank you again. And thank you to our audience who are still commenting in the chat. And I hope that you will partner with us again.
Yes.
And our next program, which we're working on right now, will be looking at the legal applications of public health and how it can impact our communities. Thanks again. And if there are no more questions, I think we're gonna say goodbye and have a wonderful week.
I have to say that it made me excited about the future of public health. So appreciate the presentations. Thank you.
Thank you.
Thank you
Take
for
care, everyone.
inviting us. Bye-bye.
Bye-bye.